Welcome back to the deep dive. We are shifting gears a bit today. We're moving away from the abstract and going into, well, full war room mode. I've got the stack right here. Miller's 10th edition, Sculpting, Katie Tripathi, Morgan and Mikhail. And I'm really trying to put myself in the shoes of a postgraduate resident.
Right.
Specifically, someone who's, staring down the barrel of the MD anesthesiology exams at Gujarat University.
It's a very high-pressure environment. And when you look at that stack of books, it's easy to feel the tachycardia setting in. The sheer volume of information can be, well, paralyzing.
Exactly. And the mission today is to take one massive cornerstone topic, benzodiazepines, and just strip it down to the studs. We aren't just reading a chapter. We're trying to build the ultimate audio revision guide. The goal is that by the end of this, you, the listener, can walk into an exam hall, visualize the receptor, and just, write that perfect 20-mark answer.
And benzodiazepines are the perfect candidate for this because they are, frankly, inescapable. You cannot get an MD in anesthesia without mastering this class of drugs.
It's guaranteed to be on the test.
It's going to be there. It might be the long question in your pharmacology paper. Discuss the pharmacology of benzodiazepines. It could be a short note on Midazolam versus Diazepam.
Or the Viva.
Guaranteed in the Viva Voce, absolutely. When you're discussing pre-medication or sedation or even, the agitated patient in the recovery room, this is the drug class you will be defending. You need to know it cold, from the molecular level right up to the clinical bedside.
Okay, so let's structure this exactly like that exam paper. If I'm sitting there, pen in hand, and I see that 20-mark headline, I need an opening that just screams, distinction candidate. I don't want to just say, it makes you sleepy.
No.
How do I define this chemically?
Precision is key. You start by defining the chemical structure. It shows you know what you're talking about from the first sentence.
Okay.
Benzodiazepines are psychoactive drugs defined by the fusion of a benzene ring and a 7-membered diazepine ring. That's it. That's your first bullet point. It shows you know the chemistry. Immediately after that, you list the 5 properties.
The 5 properties. This feels like the clinical mantra. Let's walk through them because this really does form the skeleton of the entire answer. Right?
It does. It's the framework. In your answer sheet, these need to be bulleted clearly. 1, sedative hypnotic.
Right.
2, anxiolytic.
Produces anxiety.
3, anterograde amnesic.
4, anticonvulsant. And 5.
5, centrally mediated muscle relaxation.
Okay, I want to stop you on number 3, anterograde amnesia. This seems to be a point where people, including me, can get a bit tripped up.
It is a classic Viva trap. It really is. The examiner asks, so does the patient forget their name? Do they forget the car ride to the hospital?
And the answer is?
An emphatic no. That is retrograde amnesia. Benzodiazepines cause anterograde amnesia. They block the acquisition of new information.
So my grandma remembers her wedding day from 50 years ago. She just won't remember me trying, 3 times to get the IV cannula in.
Yeah. That's it, exactly. And that is the gold standard for pre-medication. We want to erase the trauma of the procedure, not their biography. It acts as a barrier to new memory formation from the moment of injection onwards.
Got it. Okay. And number 5, muscle relaxation. We need to be so careful with our terminology here, right?
Yeah.
Because if I say muscle relaxation and the examiner thinks I mean rocuronium,
You're in trouble.
I'm in big trouble.
You are failing the station. Neuromuscular blockers work at the neuromuscular junction. The NMJ benzodiazepines cause muscle relaxation centrally, specifically at the spinal cord level. They dampen the motor outflow.
So it's good for a muscle spasm.
Exactly. Or a tension headache. But you cannot intubate a patient on Midazolam alone expecting a relaxed vocal cord. It's a completely different mechanism, a critical distinction.
Okay, we've laid the foundation. We have the definition and the 5 properties. Now we have to go to what you've labeled the very high yield section. GABA receptor physiology. This is usually where my eyes start to glaze over with subunits and ions. Help us visualize this. If I have to draw a diagram, and I assume I should...
You absolutely must draw a diagram. If you don't draw the receptor, you are just throwing away marks. It's that simple.
So what am I drawing?
Imagine a rosette. You're looking down at a flower with 5 petals. The GABA-A receptor is a pentameric structure.
Pentameric, okay, 5 parts.
Yes, 5 subunits arranged in a circle around a central hole.
And that central hole is the ion channel itself.
Correct. It is a ligand-gated chloride ion channel. Now, labeling the petals is what gets you the points. The most common isoform in the adult brain consists of 2 alpha subunits, 2 beta subunits, and 1 gamma subunit.
2 alphas, 2 betas, 1 gamma. Got it.
Correct. Now, normally in your brain, your body releases the inhibitory neurotransmitter GABA.
Right.
GABA binds to this receptor, specifically at the interface between the alpha and the beta subunits.
Okay, so GABA hits the alpha-beta gap. Then what happens to the channel?
The central pore opens, and chloride ions, which are negatively charged, rush into the neuron.
Okay, a flood of negative charge.
And because you are flooding the cell with negative charge, the transmembrane potential drops, it becomes hyperpolarized.
Hyperpolarization. So the cell moves further away from its firing threshold. It's harder to get it excited.
Exactly. It becomes resistant to excitation. It's much harder to fire an action potential. That is nature's off switch. That is how your brain calms itself down.
So that's the baseline physiology. Now we introduce the benzodiazepine. This is the mechanism of action, the absolute core of the exam. The drug enters the system. Where does it go? Does it fight GABA for that alpha-beta spot?
No, and this is the specific exam question. Benzodiazepines are allosteric modulators, a key phrase.
Allosteric.
They bind to a completely different site. They bind at the interface of the alpha and gamma subunits.
Alpha and gamma, not alpha-beta.
Correct. And here is a little nugget for the high achiever, the person who wants to get the highest marks. The gamma subunit is absolutely required. If a receptor isoform doesn't have a gamma subunit, the benzodiazepine literally has nowhere to park. It will not work.
That's a great detail. So the benzo sits at the alpha-gamma interface, but it's not opening the door itself, right? It's not like kicking the door down.
No, not at all. Think of the benzodiazepine as a cheerleader for GABA, or maybe a lubricant for the lock. It increases the receptor's affinity for GABA. It just makes the GABA that is already there work better, more efficiently.
Okay.
And this leads us to probably the most famous distinction in all of pharmacology: frequency versus duration.
Benzodiazepines versus barbiturates. I feel like I've heard this comparison 1,000 times, but let's just nail it down once and for all.
Let's do it. It's simple, really. Benzodiazepines increase the frequency of chloride channel opening events. So, in the presence of GABA, the door opens and closes more often.
Okay, more frequent openings.
Barbiturates, on the other hand, increase the duration. The door stays open for longer each time it opens.
I used to have a mnemonic for this, something like Benzos buzz, Barb's block. Benzos make a buzz open and closed faster, more frequently.
That works. That's a great way to remember it. But the critical safety implication here is this. Because benzodiazepines only facilitate GABA, they essentially have a limit. They can only work as hard as the amount of GABA present allows them to. This creates a ceiling effect.
And this is why it's very hard to kill someone with just Midazolam.
Precisely. You reach a plateau of CNS depression, you'll get sedation, you might get light anesthesia.
Yeah?
But you will very rarely get the flatline coma or fatal respiratory depression that you see with barbiturates.
Right on.
Because barbiturates at high doses can pry that channel open all by themselves without any GABA at all. They can directly activate it.
So, to use a bad analogy, barbiturates hold the gun and pull the trigger. Benzos just help you pull the trigger if you're already holding the gun.
That is a slightly dark, a very accurate analogy, yes. That ceiling effect is your primary safety argument for why benzos replaced barbiturates in modern practice.
Now, before we leave the receptor, I saw a note in the outline about subunit specificity from the new Miller 10th edition. This feels like, top-tier distinction-level material.
It is. This is for the student aiming for the gold medal. We used to think the receptor was just one big on-off switch. Now we know different alpha subunits mediate different clinical effects.
Okay, break that down.
The alpha-1 subunit is responsible for sedation, amnesia, and the anticonvulsive effect.
Okay, the sleepy, forgetful part.
Exactly. The alpha-2 subunit, on the other hand, is responsible for anxiolysis, the anxiety relief, and that central muscle relaxation we talked about earlier.
So why does a clinician care about that level of detail?
Because that is the entire future of drug design. Imagine a drug that could be developed to only hit the alpha-2 subunit.
We could treat someone's anxiety
Without making them sleepy or erasing their memory. That is the holy grail of psychiatric pharmacology. If you mention this subunit specificity in your essay, you are signaling to the examiner that you are up to date and reading the current literature.
That's fascinating. Okay, let's move from the microscope to the whole body. Pharmacokinetics. This is always high yield for the written paper. We need to talk about how these drugs move around.
Let's focus on the big three you'll be asked about: Midazolam, Diazepam, and Lorazepam.
Right.
First point. Lipid solubility, they're all relatively lipid soluble. That's why they cross the blood-brain barrier so fast and work quickly. But
Right.
midazolam, well, midazolam has a magic trick.
The pH trick, the open ring, closed ring phenomena.
Yes, exactly. In the ampoule, in the vial, midazolam is kept at a pH of about 3.5. It's acidic. At this pH, the imidazole ring in its chemical structure is open. This makes the molecule water-soluble.
And water-soluble means, for me, clinically.
It means you can dissolve it in water. It doesn't hurt when you inject it intravenously. Now compare that to diazepam. Diazepam is fundamentally water-insoluble. It's like oil.
So how do they even make an IV version?
To get it into an IV form, they have to dissolve it in something called propylene glycol. It's an organic solvent. It's basically antifreeze.
Which burns like fire when you inject it.
It causes significant pain on injection and a very high risk of thrombophlebitis. Midazolam solves that problem. But the real magic happens when you inject midazolam into the bloodstream.
Where the pH is neutral?
The word pH is 7.4. At that physiological pH, the imidazole ring closes. It snaps shut.
And that changes its properties.
Completely. When it closes, it becomes highly lipid soluble. So it's water soluble in the bottle, which means it's painless to inject. And it's lipid soluble in the body, which means it penetrates the brain very rapidly.
Open in the bottle, closed in the body.
That is a beautiful Viva answer. It shows you understand the physicochemical properties.
Okay, let's talk about metabolism. This is where the whole concept of the hangover comes from, isn't it?
It is. This is critical for discharge planning and for ICU sedation. Diazepam is metabolized by the liver via the CYP450 system, but it's what you might call a dirty metabolism. It breaks down into active metabolites.
Active metabolites, so the leftovers are still working.
The leftovers are still working. Exactly. And those leftovers, particularly desmethyldiazepam and oxazepam, have massive half-lives. Desmethyldiazepam can stay in the system for up to 100 hours.
Wow.
So if you give a patient diazepam, they might still be drowsy 24 or even 48 hours later. That's the hangover.
And midazolam, by contrast.
Midazolam is much cleaner. It does have one weekly active metabolite, 1-alpha-hydroxymidazolam, but it is very rapidly conjugated and excreted by the kidneys. So unless the patient has severe renal failure, it doesn't really accumulate.
Then there's the third player, lorazepam. Where does that one fit in?
Lorazepam is your liver safeguard. Remember that. It bypasses that whole oxidative phase of metabolism. It goes straight to glucuronide conjugation. And the most important part, it has no active metabolites.
So if I have a patient with liver failure, cirrhosis, jaundice, and they need sedation,
lorazepam is the theoretically safer choice. It puts the least amount of strain on the diseased liver.
okay, one more kinetic concept that always scares students, context-sensitive halftime. It sounds so complicated.
It does, but let's use an analogy. Visualize a sponge. If you give a single shot of a lipid-soluble drug like midazolam, the patient gets sleepy, but then they wake up fairly quickly. Why?
Not because it's gone.
Not because the drug is destroyed, but because it redistributes. It moves rapidly from the brain, which is vessel pitch, into the fat and muscle tissues.
The sponge soaks it up.
Right. But what if you run a midazolam infusion in the ICU for 4 days straight? That sponge gets completely full. The fat and muscle compartments are saturated. Now, when you turn the infusion off, redistribution cannot happen.
There's nowhere for it to go.
The drug has nowhere to go. It is trapped in the plasma and has to be slowly eliminated by metabolism.
So the context is how long the infusion was running for.
Exactly. As the duration of the infusion increases, the time it takes to wake up, the half-time shoots up dramatically. For midazolam, after a long infusion, your patient might not wake up for days. This is why we sometimes switch drugs in the ICU or perform daily sedation holds to let that sponge wring itself out a bit.
That makes so much more sense. Okay, let's pivot to pharmacodynamics.
Yeah.
What the drug does to the body. We've covered the CNS stuff, sedation, amnesia. What about the heart and the lungs? As anesthetists, we are obsessed with stability.
Cardiovascular stability is really the main selling point. Compared to propofol or the barbiturates, benzos are very gentle on the heart.
So less hypotension.
Much less. They cause a minor drop in blood pressure, mainly because they slightly lower systemic vascular resistance. They are vasodilators, but they are very mild ones.
I've heard it described as a nitroglycerin-like effect.
Yes, that's a good way to put it. In patients with high filling pressures, say in heart failure, benzos can actually reduce preload and be beneficial. But for a normal patient, the BP drop is usually very mild. Unless
There's always an unless.
the patient is hypovolemic, If they are bleeding out or severely dehydrated, their sympathetic tone is the only thing keeping their blood pressure up. If you take that away with a benzo,
Even a mild drop can be a catastrophe.
it can be significant. But in a stable patient, they are considered cardiostable.
What about the lungs? This is the danger zone.
This is the danger zone. Respiratory depression is dose-dependent. But the specific phrase you want to use in your exam is blunted response to hypercapnia.
Explain that for me.
Normally, if your carbon dioxide level rises, your brainstem gets a powerful signal that yells at you to breathe faster and deeper.
Right.
Benzodiazepines flatten that response curve. The CO2 goes up, and the brain just kind of shrugs. It doesn't care as much. The drive to breathe is diminished.
And what about the airway itself? The physical pipe?
This is, frankly, the killer. Benzos relax the muscles of the upper airway, particularly the genioglossus muscle, which holds the tongue forward. The tongue falls back. You get obstruction.
So the patient could be trying to breathe?
But the airway is closed. This is why snoring after a dose of midazolam is not a good sign. It's not peaceful sleep. It's an obstruction sign.
Let's look at the specific agents. We've got the big three, but there's a newcomer mentioned in Miller 10th edition, Remimazolam.
Remimazolam, yes. This is the really exciting development. You know of remifentanil, the opioid that's metabolized so fast it basically disappears in minutes?
Yeah.
Remimazolam is the benzodiazepine version of that concept.
How does it work?
It's what's called a soft drug. It's designed with an ester linkage in its structure, and that linkage is rapidly broken down by non-specific tissue esterases that are just floating around in the blood.
So it doesn't need the liver or the kidneys.
It doesn't need either. It's independent of organ function. You turn the infusion off, and the drug is gone in a matter of minutes.
That sounds like a complete game changer for short procedures, procedural sedation.
It is. It's gaining a lot of traction for things like endoscopies. Fast on, fast off, predictable recovery. For your exam, just mentioning it proves you are reading the latest literature. It separates you from the crowd and shows you understand the evolution of the drug class from long hangover to precise control.
Okay, let's talk clinical uses. We use them for pre-medication, for induction. Why would I ever choose a benzo for induction over something fast like propofol?
One main reason, hemodynamic stability. If you have a patient with, say, severe aortic stenosis or severe cardiac compromise, a bolus of propofol might cause their blood pressure to crash completely. A slow titration of midazolam is much, much gentler on the cardiovascular system.
But you have to be patient.
You have to be very patient. It takes a lot longer to work. It's not a rapid sequence induction drug.
Procedural sedation. This is the bread and butter use, isn't it?
It is. Endoscopies, bronchoscopies, dental work. The goal is what we call MP-monitored anesthesia care. You want the patient comfortable, amnesic, but still maintaining their own airway and breathing. Benzos are great here because they're so titratable.
You can just give a little bit at a time.
Exactly. Give 1 milligram, wait a minute, see the effects, give another milligram, it's controllable.
Okay, Section 8 covers ICU and emergency care. Two huge conditions here, status epilepticus and alcohol withdrawal.
For status epilepticus, a continuous seizure, benzodiazepines are the absolute first-line treatment. Lorazepam or Diazepam intravenously. They work by raising the seizure threshold almost instantly. You are flooding the brain with agargic inhibition to stop that electrical storm.
And for alcohol withdrawal,
Yeah.
it seems counterintuitive.
It does, but it's a fascinating mechanism. It all works because of a principle called cross-tolerance.
Break that down for me.
The brain of a chronic alcoholic is constantly bathed in alcohol. Alcohol also works on the GABA receptor, enhancing its function. The brain gets used to this constant inhibition, so it tries to compensate by downregulating its own GABA receptors and upregulating excitatory systems.
So it's fighting back.
It's fighting back. Then you suddenly stop the alcohol, the brain panics, the brake is gone, but the accelerator is still floored. You get this massive, unopposed excitation that's delirium tremens.
Who use the benzo as a substitute for the alcohol.
Precisely. You are plugging that GABA receptor with a benzodiazepine, which the brain recognizes as being very similar to alcohol, and then you can slowly, carefully taper it off over days. You're basically landing the plane gently instead of letting it crash.
That's a great explanation. Now let's talk about the dark side, Section 9, adverse effects.
Yeah.
We need to talk about what you call the synergy of doom.
If you remember only one thing from this entire deep dive for patient safety, let it be this. Synergism with opioids.
It's not just additive.
It is not 1 + 1 = 2, it is 1 + 1 = 10. Benzodiazepines alone have that ceiling effect we talked about. Opioids alone cause respiratory depression, but when you mix them, even small doses of each
A little bit of Midazolam, a little bit of fentanyl.
can cause complete apnea. This is the most common cause of death by sedation in endoscopy suites or dental offices around the world. The hypoxic drive is gone, the CO2 response is gone, and the airway collapses.
It effectively removes all of the body's safety nets at once.
All of them. When you combine these two drug classes, you must reduce the dose of both significantly, and you must be prepared to manage an airway, period.
What about the paradoxical reaction? I've seen this in kids. You give Midazolam to calm them down before surgery, and they go absolutely wild.
Paradoxical excitement, yes. It's most common at the extremes of age in children and in the elderly. Instead of getting sedation, you get aggression, agitation, uncontrollable crying, and confusion. It's a complete nightmare.
Do you know why?
The theory is that it's due to disinhibition. It's like being a mean drunk. The parts of the brain that control impulses and social behavior are sedated first, unmasking these other behaviors.
So in the elderly specifically, this is a big problem.
In the elderly, we try to avoid benzos if at all possible. They are a major cause of postoperative delirium and postoperative cognitive dysfunction, or POCD. It can scramble their brain for days. Their metabolism is slower, their blood-brain barrier is leakier, the receptors are more sensitive. The general rule is to halve the dose, or better yet, just don't use them.
Okay, Section 10, drug interactions. We've hammered home the point about opioids. What about ME reduction? This is anesthesia lingo.
M, minimum alveolar concentration. It's the concentration of a volatile gas, like sevoflurane, needed to prevent movement in 50% of patients. Benzodiazepines reduce the amount of gas you need to keep a patient asleep.
By how much?
They can reduce MAC by up to 30%. That's significant. It means you use less gas, which means less vasodilation from the gas, which can lead to better blood pressure stability.
So it's a useful part of a balanced anesthetic technique.
Correct. And what about enzyme inhibitors?
Right.
You need to be aware of common drugs like erythromycin, an antibiotic, or diltiazem, a calcium channel blocker. These drugs inhibit the CYP450 enzymes in the liver.
The same ones that break down midazolam.
Exactly. So if a patient is on these drugs, they cannot metabolize midazolam efficiently. The effect will be much stronger and last much, much longer. You have to reduce your dose.
Section 11 is a crucial add-on. The antidote.
Flumazenil.
Flumazenil, the get-out-of-jail-free card.
Or is it? Flumazenil is a specific competitive antagonist. It flies in, lands on that benzodiazepine binding site on the GABA receptor, and kicks the benzodiazepine off. It reverses the sedation, often instantly.
But there is a massive trap, the half-life trap.
Yes. This is a critical safety point. The half-life of flumazenil is very short, about 1 hour. The half-life of most benzodiazepines is much, much longer. So you give the flumazenil, the patient wakes up, you high-five your team, and you send the patient to the recovery room or the ward.
And then an hour later?
The flumazenil is metabolized and gone, but the benzodiazepine is still floating around in the patient's blood. It rebinds to the now empty receptors, and the patient gets resedated.
And if they're unmonitored on the ward,
They can obstruct their airways, stop breathing, and die. It's a never event. If you use flumazenil, you have effectively bought yourself at least 2 hours of mandatory close observation of that patient.
mandatory.
You cannot send them home. You cannot send them to an unmonitored bed. You are married to that patient for the next few hours.
Are there times we should just never use flumazenil?
Absolutely. Number 1, a patient with chronic benzodiazepine dependence. If you give flumazenil, you will precipitate acute violent withdrawal. You can cause intractable seizures.
Okay.
Number 2, in a mixed overdose, especially with tricyclic antidepressants, TCAs cause seizures, but the co-ingested benzodiazepine is actually protecting the brain. If you give flumazenil, you remove that protection, and the TCA can cause a lethal seizure.
Wow.
And finally, you'd be cautious in a patient with raised intracranial pressure. Waking them up suddenly with flumazenil can cause coughing, straining, and agitation, which can spike their ICP even further.
These are vital safety points.
Okay.
Section 12, contraindications. We touched on the elderly and dependency. What about OSA? Obstructive sleep apnea.
That's a huge one. These patients already have a floppy upper airway. They rely on their baseline muscle tone to keep it open while they sleep. Benzos relax those muscles. It is a recipe for complete airway obstruction. You either avoid them entirely or use them with extreme caution and a tiny dose.
And myasthenia gravis.
This is a subtle one. Benzos are not neuromuscular blockers, as we said, but they cause central muscle relaxation and can depress the respiratory drive. In a myasthenic patient who already has profound weakness, especially of their respiratory muscles, this can be the straw that breaks the camel's back. It can tip them into respiratory failure.
What about pregnancy?
Historically, there was a weak association with cleft lip, though the modern data is a bit mixed. The bigger concern is use near delivery. It can cross the placenta and cause floppy infant syndrome, hypotonia, poor feeding, and respiratory depression in the newborn. So generally, we avoid them unless absolutely essential.
Okay, we are in the home stretch. Section 13, common exam questions and Viva traps. So I'm going to throw these at you rapid fire. You give me the crisp examiner-approved answer.
Let's do it. I'm ready.
Trap 1. Doctor, do benzodiazepines open the chloride channel?
No. They increase the frequency of opening in the presence of GABA. They are positive allosteric modulators. They do not directly activate the channel.
Trap 2. You mentioned amnesia. Is it retrograde amnesia?
No. It is exclusively anterograde amnesia. New memory formation is blocked after the drug is administered. Existing memories are preserved.
Trap 3. Why don't we just give flumazenol to everyone at the end of the case to wake them up faster?
Because of the significant risk of resedation due to its short half-life. Also, it can precipitate seizures in dependent users and cause acute anxiety and panic. It is a rescue drug, not a routine reversal agent.
Perfect. Tab 4. What is the key structural difference between midazolam and diazepam that explains their different formulations?
Midazolam possesses an imidazole ring. This ring is open at an acidic pH, making it water-soluble, and closes at physiological pH, making it lipid-soluble. Diazepam lacks this ring and is insoluble in water.
Excellent. Finally, section 14, diagrams and presentation. I'm sitting there writing that 20-mark answer. What does my paper need to look like?
You need visuals. It breaks up the text and shows a deeper understanding. First, the GABA receptor schematic.
The Rosette.
The Rosette. Draw the 5 subunits. 2 alphas, 2 betas, 1 gamma. Use an arrow to point to the alpha-beta interface and clearly label it GABA binding site. Use another arrow to point to the alpha-gamma interface and label it benzodiazepine binding site.
What about a comparison table?
An absolute must. Make 3 columns. Midazolam, diazepam, lorazepam, then have rows for critical properties like water solubility, pain on injection, presence of active metabolites, and elimination half-life. A clear table shows the examiner you can organize and synthesize information effectively.
In a graph. Is that too much?
No, it's perfect. The dose-response curve. Draw dose on the x-axis and degree of CNS depression on the y-axis. Then draw a line for barbiturates that goes straight up, almost linear, all the way to a point labeled comma death.
Okay.
Then draw a second line for benzodiazepines that rises but then curves off and flattens out into a plateau. And you must label that plateau ceiling effect greater safety margin.
It's a 20 out of 20 answer.
It is. It covers mechanism, clinical applications, safety, and comparative pharmacology in one clear picture.
So to summarize the whole thing for the listener, the absolute take-homes. 1, receptor is GABA. They increase the frequency.
Correct.
2, safety comes from the ceiling effect.
Yes.
3, know your drugs. Midazolam is water-soluble and short. Diazepam is long with active metabolites. Lorazepam is the liver-safe one.
Perfect.
4, the biggest danger is synergy with opioids.
Absolutely critical.
And 5, the antagonist is flumazenol, but you have to watch out for resedation.
The central theme that ties it all together is safety. We prefer benzodiazepines because they are forgiving drugs, but they still demand respect, especially when it comes to the airway and drug interactions.
So I have to say, I feel much better about facing that exam question now. We've unpacked the physiology, the pharmacology, the clinical use, and most importantly, the traps.
Visualization is the key. Before you step into that exam hall, just close your eyes and picture that pentameric ring. Picture the chloride ions flowing in. Picture the imidazole ring snapping shut in the bloodstream. If you can see it in your mind, you can explain it on paper.
Huge thanks for this incredibly high-yield review.
Yeah.
And to our listener, go practice drawing that receptor diagram right now. Good luck with the preparation.
You've got this.
And a quick disclaimer, this deep dive is for educational and exam preparation purposes only. You should always consult standard medical texts and your local clinical guidelines for patient care. Thanks for listening.